My name is Sophia Sliter-Hays, and today is August 14th. Okay. I'm going to start with case 1. In the first case, a newborn quickly developed symptoms suggesting a metabolic disorder. Blood money was elevated and continued to increase to 7.5 times the value of the upper range limit. Nitrogen movement in the body involves transamination, non-toxic ammonia carriers, and several enzymes that fix and free ammonia so it can be safely disposed of in the urea cycle. The liver is the primary location for nitrogen disposal, so a system to transport excess nitrogen from peripheral tissues to the liver exists. I've taken this from LibreText section 5.3 nitrogen metabolism in the urea cycle. Transamination reactions transfer amino groups from amino acids to keto acids. This does not free ammonia, it only transfers the nitrogen. Alanine aminotransferase, which converts alanine to pyruvate, and aspartate aminotransferase, which converts aspartate to oxaloacetate, are common transferases in the body. Transamination reactions generate alanine and glutamine, which are non-toxic carriers of ammonia from peripheral tissues to the liver. There are 3 other enzymes that are crucial for the movement of nitrogen. These are glutamate dehydrogenase, glutamine synthase, and glutaminase. Glutamate dehydrogenase is in most tissues, and it can both fix and free ammonia. In skeletal muscle, it fixes ammonia with alpha-ketoglutarate, which produces glutamate. In the liver, it carries out the reverse, freeing ammonia. The direction of the reaction, fixing or freeing, is determined by NAD+/NADP+ levels, ammonia levels, and other factors. Glutamine synthetase is active in peripheral tissues. It helps transport excess nitrogen from there to the liver. It can combine glutamate generated from the glutamate dehydrogenase reaction or from transamination with ammonia to generate glutamine. Glutaminase is a liver enzyme that deaminates glutamine as it enters the liver. The free ammonia generated from this reaction then enters the urea cycle. So nitrogen transport and disposal happens in both the fed and fasted states. In the fed state, dietary amino acids will be broken down and contribute to the carbon pool. In the fasted state, the carbon skeletons from amino acid catabolism will be used for gluconeogenesis. The alanine-glucose cycle plays a key role in shuttling amino groups and glucose between the muscle and liver. Alanine is transported from the muscle to the liver, where it is transaminated to pyruvate. The amino group enters the urea cycle, but the carbons are used for gluconeogenesis to generate glucose, which is then shuttled back to the muscle where it can be used for energy and broken down to pyruvate. The cycle can continue as pyruvate can be transaminated to alanine. You follow this here, which I've taken from lecture 13.1. The infant also has elevated orotic acid levels with normal citrulline levels. This suggests a deficiency in the urea cycle, which means an impaired ability to dispose of ammonia. Excuse me. The deficiency is likely not in carbamoyl phosphate synthetase 1. Orotic acid is produced in the pyrimidine synthetic pathway, which can accept carbamoyl phosphate. Since orotic acid is high, production of carbamoyl phosphate is also likely high, meaning that this enzyme is not deficient. Since the patient has normal levels of citrulline, she likely does not have a deficiency in ornithine carbamoyl transferase. This enzyme produces citrulline from carbamoyl phosphate and ornithine. So if she has normal levels of citrulline, the enzyme is likely functioning. The deficiency is also likely not in argininosuccinate synthetase or argininosuccinate lyase. Argininosuccinate synthetase catalyzes the synthesis of argininosuccinate from citrulline and aspartate. Argininosuccinate lyase cleaves argininosuccinate into fumarate and arginine. Deficiencies in these enzymes would lead to the inability to further metabolize citrulline, and citrulline would then accumulate. As the patient has normal citrulline levels, it is highly unlikely there are deficiencies here. The final enzyme in the urea cycle is arginase. Arginase catalyzes the conversion of arginine to urea and ornithine. Deficiencies in arginase can cause increases in orotic acid, as a lack of ornithine will lead to carbamoyl phosphate being shunted with the pyrimidine synthetic pathway, since OTC activity here would be impaired. According to a paper published in Molecular Genetics and Metabolism, the only enzymatic deficiency in which plasma citrulline is normal is in arginase. In deficiencies in CPS1 and OTC, it is decreased, and in argininosuccinate synthetase and lyase, it is elevated, as I explained earlier. In this case, arginine levels were not reported, but it is likely the deficiency is in arginase, given this evidence. Arginine is non-essential on the condition that the urea cycle functions properly, as it is generated at the end of the cycle. Therefore, if there is a deficiency in the cycle before the step catalyzed by argininosuccinate lyase, then no arginine is produced, and this amino acid becomes essential. However, if the patient has a deficiency in arginase, it would not be considered essential. Okay, on to case 2. The first scenario is about an infant who tested positive for branched-chain amino acids. I'm showing a figure here from lecture 14.3 from the course. Branched-chain amino acids, which are leucine, valine, and isoleucine, are essential amino acids. To provide the primary energy source to skeletal muscle and substrates for the TCA cycle intermediates in the liver. According to a paper from the European Journal of Pediatrics, common enzymatic deficiencies in branched-chain amino acid metabolism include deficiencies in isovalyryl-CoA dehydrogenase, 3-methylcrotonyl-CoA carboxylase, 3-methylglutathione-CoA hydratase, 3-hydroxy-3-methylglutaryl-CoA lyase, and 2-methylacetoacetyl-CoA thiolase. However, we obviously did not discuss these enzymes in the course, so I will not talk about them. Instead, it's possible the patient has a deficiency in branched-chain amino acid decarboxylase or dehydrogenase, which would lead to an inability to decarboxylate the keto acids here and impair metabolism of leucine, valine, and isoleucine. The branched-chain amino acids are essential. However, in patients with branched-chain amino acid metabolic disorders, the amino acids and their keto acids can accumulate to dangerous levels. And we discussed maple syrup urine disease, a branched-chain amino acid metabolism disorder caused by deficient oxidative carboxylation of the metabolites of valine, leucine, and isoleucine. As this disorder is caused by a deficiency in an enzyme that requires thiamine as a cofactor, thiamine supplementation may offer some benefit to the patient, as the decarboxylation step here could occur. However, the primary management of branched-chain amino acid metabolic deficiencies involved restricting dietary consumption of said branched-chain amino acids. So for scenario 2, it's about a woman with joint pain and pigmented macules. So based on her symptoms, there is likely a deficiency in homogentisate oxidase. Sorry for mispronouncing that, which is an enzyme in tyrosine metabolism, right here. A deficiency in this enzyme can lead to alkaptonuria, or an accumulation of homogentisate or homogentistic acid. This can cause heart damage, arthritis, and hyperpigmentation of certain tissues. As the step that this enzyme catalyzes is downstream of tyrosine and then phenylalanine, which is further up here, no amino acids will become essential as a result of this deficiency in this enzyme. And there are no vitamin supplements to relieve this condition. So for scenario 3, this scenario is about an infant with elevated phenylalanine. I'm showing a figure here from LibriText section 8.1. The patient has an accumulation of phenylalanine, which is likely caused by a deficiency in phenylalanine hydroxylase, which catalyzes the relimiting step in the breakdown of phenylalanine to tyrosine. Mutations in this gene cause phenylketonuria, since phenylalanine is no longer metabolized or metabolized at very low rates. Phenylalanine is converted by phenylalanine hydroxylase to tyrosine. In the case of deficiency in this enzyme, tyrosine becomes an essential amino acid because phenylalanine is obviously no longer being broken down to tyrosine. And finally, phenylalanine hydroxylase requires tetrahydrobiopterin as a cofactor. If there is a deficiency in this cofactor, supplementation may be recommended and would help with the conversion step that phenylalanine hydroxylase catalyzes. However, this may not benefit patients that have defects in the phenylalanine hydroxylase gene rather than deficiencies in the cofactor. Regardless, patients must follow a diet low in phenylalanine to avoid dangerous accumulation of this essential amino acid. Thank you.